All right, good morning. It's glad to be here. Nice that the air conditioning is working here up in Frisco, but more importantly, we're excited for another edition of Coffee, Kids, and Sports Medicine. And I have the distinct pleasure of introducing Jason Petrasic. And Jason Petrasic really, he started medical school back in San Antonio, same place I did. Great people seem to come from there. And then he did his residency at UT Southwestern, where I think he started an interest in looking at adolescent back pain. He even did a randomized controlled trial looking at bracing for chronic back pain. And so he continues to have a professional interest in adolescent back pain. And let me tell you, as many times as we've heard and we've discussed about the epidemic of ACL injuries in our kids and overuse injury in our kids, I would tell you that back pain is also becoming an epidemic in our youth athletes. So we're really fortunate that Jason has joined our team to become really an expert in adolescent back pain, and he's going to talk to us about that today. So Jason, it's all yours.
Thank you. All right, well, thank you for having me today. Very glad to be here. All right, so I don't do too well behind a podium. I'm going to kind of step out a little bit. Also feel a little bit like Matt Foley, motivational speaker right now. I'm not used to the ear mic, so bear with me if I hit it on accident occasionally. But I'm going to talk to you guys a little bit more today about back pain, specifically in adolescents. Oh no. All right. Maybe not. Be standing here. So there's the objectives today. First of all, when we talk about back pain, first of all, you got to kind of decide how you want to define back pain, at least clinically, and not only clinically, but for research. I think everybody would when you look at studies, when researchers try to study back pain, you have to settle on, okay, well, how do we want to define this? What is clinically relevant back pain? And that's tough because, as most studies will discuss, the definition isn't widely agreed upon. Looking at a few different studies, one of the best ones that I found and one of the best definitions, at least that they used, was back pain that interferes with school, work, or leisure activities and any non-occasional pain that in some way limits the student's daily activities. But I think that's more relevant there because it implies that there's an impact on the quality of life and an impact on function, not just kind of your day-to-day, hey, it hurts a little bit. Treatment seeking is often used as well to indicate significantly impactful pain. So not only somebody that's having pain, but they're willing to go out and have somebody evaluate them for. They want it to feel better. It's bad enough that it's impacting them. So in order to really evaluate that, we've also come up with, or various outcome measures have evolved that exist to better help objectively measure the impact of back pain on function, mental health, disability. A couple that we use here that are very popular. One is the Oswestry Disability Index, or ODI for short. We also use the Pediatric patient-reported outcome measures, the PROMIS scores, amongst many others in all of our departments. But they help us to more objectively evaluate this back pain, and not only that, but response to treatment that these patients come seeking. But our challenge really becomes, especially in adolescents and pediatrics in general, when compared to adults, where adults deal obviously more with, over time, the degenerative aspects of bone, joint, and muscle disorders. In kids, it's more about the growth and development. How does the growth and development and open physes and that growth and development contribute to the generation of back pain symptoms or back pain injuries? So just first and starting, and a little bit of what are the numbers? How common is back pain in kids? There was a really good study done in an epidemiological study done for looking at back pain in American children and adolescents, and specifically it was done in 2020. It looked at the frequency of back pain characteristics just within the last year. And couple of the things I highlighted there that I thought were particularly interesting. It was a review of a large number of patients, so over 3,600 kids. And just looking at the most common sites or locations cited for back pain, 23% reported pain in the low back of the entire population, whereas 14% in the upper back, 5% in the neck, so another 20% in the upper back and neck. And then just setting aside the percent of participants, of those study participants that reported back pain within the last year, which was over 1,200, almost 47% reported a duration of pain of less than 1 month, and another 23% reported a duration of pain for 1 to 3 months. So really in total, you've got almost 70% of your population that reported back pain really had symptoms less than 3 months. So not necessarily more chronic symptoms. But that's still a large number. This was just another graph pulled from that same study, and I thought it was an interesting graphical representation. The top line there represents the participants that just reported back pain. They did not seek treatment. So you can see it was quite a bit more, and not only by age, it almost in a linear direction went up to nearly 50% by the age of 18. And about half that population at each age level, and the line below that were participants that actually sought treatment for their back pain. So I think it also bears mind that when you look at studies, a lot of studies that look at the incidence or prevalence of back pain are done in centers that people come seeking treatment for their back pain, but it's not necessarily representative of the entire population. And lastly, just wanted to include one graph. This is currently unpublished data, but from a study an internal study that we're looking at writing up right now. And this was a look at back pain prevalence by age and referrals to Scottish Rite, simply not for back pain, but just for a spine problem, generally a spine concern. And we looked at all those patients over a defined period that reported back pain symptoms, and you can see there that by age, it's pretty astounding that by 14 or 15 years old, it starts to kind of plateau a little bit, right around 50% reporting back pain. So it's not necessarily an uncommon problem as many patients and parents may think. So another concept I want to just think about before we kind of move on is the concept of, are you injured or are you hurt? And with a lot of sports medicine folks here today, you already kind of know this, but I like to think of it, or I think the best way to sum it up was I think done from the movie The Program, and there's a kind of a famous scene or a quote from that movie that was done in 1993. And it occurs after a running back is knocked down on the field. It's a college football team. The coach runs up to him on the field, looks down at him, and he says, "Well, son, are you injured or are you hurt?" And he looks up at him. He's a little dazed. He says, "What does that mean, coach?" He says, "Well, if you're injured, you can't play. If you're hurt, you can still play." He goes, "Well, I don't know, coach. I guess I'm just hurt." And he kind of helps him up, gets him up, and he pats him on the butt and gets back on the field. But I think that's a good concept to understand, and what I try to explain to kids a lot of times when they come in is, I'm here to help you to figure out if you're injured or if you're just hurting. If you're injured, then we'll probably need to treat this much more conservatively, and I go into specifically what that means. But if you're just hurting, you can probably maintain some of your activity level while we do more of an active treatment. So I think that is a helpful concept for them to then understand too, because it may be a first for them as well. Many of these kids have never been injured before. So based on the history, current symptoms, and the physical exam, how likely is it that there's a spine or a soft tissue injury? And what else could cause back pain when a structural injury is not present? So I like this graph on the right side of the screen, or excuse me, the picture on the right side of the screen, that just gives you an idea of when you're thinking about somebody that's complaining about back pain symptoms to you, How can I picture it in my mind or conceptualize it so that I kind of understand the mechanical forces that are going on? So when you look at the spine, I like to use the three-column model, and I've touched on this on some other talks I've given before, but the three-column model that was really extrapolated from spine trauma, or spine injuries in the trauma setting where there are issues with multiple spine fractures. And so you get into the idea of instability. But it also, I think, works when you're looking at the mechanical forces at work. So you've got your anterior column there highlighted in blue in the anterior portion of the spine that consists primarily of the anterior two-thirds of the vertebral bodies and the anterior two-thirds of the intervertebral discs. On the yellow portion is the posterior elements. That's the posterior column. And it's primarily consists of the spinous processes, the interspinous ligaments, the facet joints, but also the pars interarticularis. And then the middle column, while it does include the posterior one-third of the vertebral bodies and the intervertebral discs, it also includes the spinal canal, the spinal nerve roots, the spinal cord up higher in the spine. So when you're looking at the dynamic movement of the spine, you've got forward flexion. What's that going to do? Forward flexion is going to put more pressure on the anterior column when you bend forward. When you bend backward, it's going to put more force and pressure on the posterior column. Now, one way we know that is, that's why I've got the picture from a famous study there on the left. It's just pulled that nice table from a study done by a guy named Alf Nachemson, where a lot of this stuff comes from back in the late 70s and early 80s, actually, where he looked at surprisingly healthy subjects at that time. They volunteered, so I'm not sure why they did that, but they did. And what he did was he measured pressure in the discs with patients. He started with cadavers, but then moved on to healthy subjects, and measured the pressure in the discs of healthy patients when they were in various positions: lying supine, seated, standing upright, forward flexed, standing upright, forward flexed, holding weight, twisting, those kind of maneuvers. And that's represented in the numbers there on the right in newtons. So that's a unit of force. And you can kind of tell just lying supine, flat on your back, in traction with force, there's zero force on the disc. But just lying supine and awake, without that same traction, there's increased force there, about 250 newtons. Well, when you move to an upright seated position without support, you go down and there's actually 700 newtons of force. So that's nearly 3 times the amount of force on those discs. And then you move further down when you're standing upright, forward flexed to about 20 degrees, rotated about 20 degrees, and holding 10 kilograms of weight. That was the highest force he recorded. Up to 2,100 newtons. And so if you think about it too, looking back at that picture on the right, if you're forward flexed and twisted, that's putting a lot of extra force on those discs. And what happens when there's too much force on a disc, on a pliable object, especially when there's a weakness in the posterior wall, that disc, the inner portion of that disc, the nucleus pulposus, may want to, in somebody who's genetically predisposed, sometimes may want to herniate posteriorly. So anyways, I thought a good way to conceptually think about the forces at work there. So I want to start with one case, kind of get you thinking a little bit. Got a 14. These are extrapolated from a couple patients of mine, so they're real cases. 14 plus 6-year-old, no names, no identifiers. 14 plus 6-year-old male baseball player. He's a pitcher, also plays outfield, with 3 to 4 weeks of progressively worsening low back pain. It's worse while running, throwing, after practice. It's intermittent but daily and moderate to severe when present. He denies any neurological symptoms. Pain doesn't wake him up at night. So that's helpful and important. Additionally, pertinent physical exam findings. He has full active range of motion in the lumbar spine, so forward flexion, rotation, side bending. Pain with lumbar hyperextension, flexion some, and lateral bending as well. He's tender to palpation in the right lower lumbar paraspinals and the vertebral lateral elements. On special testing, he has a or Kemp test, as some call it, that's positive on the right side, and then popliteal angles of 45 degrees bilaterally. Any thoughts from the crowd that's here today? Any ideas? What would you want to do next? Do we want to start with X-rays? Do we want to start with just? Do you think we can forego that and just do some treatment? How about we start with X-rays? Good idea. Yeah. So I'll tell you, those were negative. Those were normal. So if I tell you those were negative, what would you want to do next? You think you want to just go ahead and treat them based on normal X-rays in this guy, and taking in all factors. Again, some of the more important things, he's a pretty avid baseball player. It's more acute pain. It's only been present for 3 or 4 weeks, and it seems to be more severe right now. It's activity related. It's not constant, thankfully, but it is mainly with his activities, and there's kind of an extension bias to his symptoms. He's got pretty tight hamstrings, as his popliteal angles. That's what that's really used to evaluate, is the range of motion or range of motion restriction in the hamstrings on both sides. So now, kind of knowing that, still with normal X-rays, you want to go ahead and let him start some conservative management, or do you want to get some additional imaging? Yeah, it'd be reasonable. That wouldn't be unreasonable. But I'll tell you, I went ahead and got an MRI, mainly because, and this is a controversial topic, because a lot of people would just treat, or some would just treat presuming that there might be a stress fracture, because that's the main concern I would have in this kid right now. And you wouldn't necessarily be wrong, but I'll tell you, a lot of kids who play sports and are real avid athletes that have paid a lot of money to for 3 months be on a traveling baseball team, just sitting out for 3 months and not really knowing for sure what's going on, they don't get real happy about that. So a lot of times in those particular situations, I will go ahead and get an MRI to confirm up front what we're treating if I have a high index of suspicion for it. And that was the case in this individual. And his MRI didn't ultimately end up showing that. There on the right, it shows the more typical sequence on the T2 image. At the L5 level, you can see that marrow edema, the increased hyperintensity, the increased signal where the arrow is pointing. That's indicative of edema in the pedicle and the pars interarticularis, indicative of a more acute fracture. And on the left side, it's a nice, unique sequence that our radiologists here do. It's a bone window sequence that looks more similar to a CT scan, which is great. You kind of more easily see the actual fracture line there in the pars interarticularis at L5. So that's what I ultimately treated it as. So a little bit about that. So yeah, Dr. Ellis.
Could you go back to that case? I think this is...
So I'll tell you how I do it. It's going to be a little different depending on the comfortability level of the provider who's seeing the patient. In particular on this case, again, it's regardless of athlete, it's a high demand patient. I didn't go into a whole lot of detail on his number of hours, how many innings he pitched, what's his pitch count every week. But I'll tell you, he was a very competitive baseball player, spends a lot of time, most of the year, playing baseball. It was progressively worsening. It was also more severe. It wasn't just kind of mild, intermittent, kind of aches and sore. It was pretty severe pain he was complaining about. He was in that age range. So an adolescent, these spondylolysis fractures are much more male predominant, not much more, but they're more male predominant than female predominant. And in the males, it more often tends to occur in the 14 to 16-year-old age range. And almost universally, if I'm even thinking about it, and it's in my mind, I'll look at the parents and say, but he has really tight hamstrings, doesn't he? And they almost always, every time, not necessarily all the females, but the males always seem to have really tight hamstrings. So that was one indicator there as well. Thankfully, there weren't none of the neurological symptoms, no constitutional symptoms that raised concern. But it was the high demand patient in the age range that I have a high index of suspicion for. And then also, he's tender in that approximate L4, L5 level. When I did the provocative testing, he didn't necessarily have, or he had pain with hyperextension. A lot of times I won't even go forward with doing a stork test or a provocative extension test because I already know they're painful just with basic hyperextension. But sometimes I'll do it, again, just for confirmation, especially if it was kind of a equivocal answer. And then also the popliteal angles, the 45 degrees. So just with all of that, but again, it's keeping that high index of suspicion for this type of an injury in a high demand patient, in particular athletes, and in particular if there's an abrupt, and I'll get to that here in a second, but an abrupt change in their training regimen or in particularly susceptible sports or positions within certain sports like offensive linemen within the sport of football, divers, gymnasts, those kind of activities. Those usually do it for me. But again, if he's a lower demand patient, and me telling him, hey, no high impact activities, no avoid lumbar hyperextension and rotation, but they're a sedentary kid, it's not going to impact their next 2 or 3 months ahead, then I don't necessarily need to get an MRI. I can just tell them about that, educate them on what I think is most likely the diagnosis, start treatment, and then see them back in 2 or 3 months and see how they're doing. We don't necessarily need to get an MRI to confirm that. But if they don't respond to treatment or don't respond to management, okay, then we get it. So it's just being diligent about using that resource. So a little bit, just going into a little bit of detail about that specific type of injury. You can see the origination there. It's from the Greek language. There is a lot of general confusion, both in the public and even in kind of the medical circles about what's acute versus chronic, what if it's symptomatic, what if it's found incidentally in an asymptomatic patient, how do you manage these, what do you do? And often that confusion to some degree gets transferred onto the patient because you may, depending on what you call it, there's multiple different kind of terminology for it. You got spondylolysis, pars defect, pars fracture, and they all kind of mean the same thing. But in general, I've evolved to using more the chronic asymptomatic developmental problem. I refer to that as a pars defect. Whereas if it's more of an acute fracture, I'll say an acute spondylolysis or acute pars fracture. But just when they're in the development, a non-acute fracture, there's an incidence of at least 6% by the end of childhood. So we know from good studies that babies aren't typically born with this, so it's not a congenital defect, but it typically occurs in somebody who's genetically predisposed and usually sometime within early childhood development. Some people think it's from early repetitive microtrauma to the spine, but in some people it may take even less stress than that. So genetics play a role. Like I mentioned before, it predominantly affects males a little bit more than females, more common in athletes. And again, most often when in the acute setting, in the acute symptomatic setting, it's often due to repetitive mechanical stress, similar to what I was describing earlier. Treatment usually really boils down to getting them to buy into really resting. Resting is the biggest thing, but I call it an active rest. You know, you're not bed rest. It's not that you can't do anything for the next 2 to 3 months. Look, there's going to be a period of rest to let things heal, but as your symptoms start getting better, that's when we're going to start involving physical therapy. And I tell them physical therapy is going to play a major role in this, not only from helping you heal from this injury, also helping you transition back to sports successfully, but for even further, helping you prevent recurrence of the injury once you recover from this problem. And so really getting them to buy into that. And that may be 1 month for some kids, it may be 2 to 3 months for some kids. It just depends on how long their symptoms last. Bracing is done relatively commonly, but it's somewhat controversial. There's various conflicting studies that support bracing, some that are against it. Some literature is coming out that supports it in favor for certain types of these fractures, because as you can imagine, this can occur unilaterally at L5, it can occur bilaterally L5, it can occur unilaterally at multiple levels, it can occur unilaterally or bilaterally at L3 or L4. So we're kind of beginning to find out that it may matter where it occurs, and some that occur more superiorly in the spine are, although a little more rare, have a tendency not to heal as well, and often contribute often to more prolonged symptoms. So the average return to play here is, I typically tell kids up front, it's going to be about 2.5 to 3 months. That's return to play, not just for you to recover, but to be patient, because sometimes it can take as long as 6 months or more, and it's primarily guided by symptom resolution. Secondarily, we look for bony union and full bone recovery, but it's pretty common, especially in certain types of these fractures, for there not to be a bony for bony union not to occur. Even when that happens, it's believed that a lot of that gap or that defect in the bone may fill with a fibrous scar tissue that helps keep it stable. But nevertheless, a lot of these don't actually heal, but that doesn't mean prolonged symptoms still occur. So next I want to talk about intervertebral disc herniations, and this is with or without radiculopathies. Radiculopathy is just a medical way of saying an irritated or inflamed spinal nerve root. So I wanted to start just with a pictorial representation, and there's a transverse or axial cut there on the right, a sagittal cut there on the left, and it just shows that herniated disc, not only the herniated disc, but what a herniated disc could potentially do to the spinal canal if it herniates centrally, or to the neuroforaminal canal and the spinal nerve root that's exiting at that same level if it herniates more far laterally. Excuse me. The prevalence of this in adolescents is only about 0.2 to 1%. In adults, it's as high as 40%. So you can imagine there's kind of a spectrum. As kids get older, it starts becoming a little bit more common until early adulthood. So I tell kids it's rare, but it does happen. There's several causes. It can be trauma or sports related. There's a genetic predisposition that can contribute to this. And certain vertebral anomalies like scoliosis or transitional vertebra can also contribute to why these develop in some kids. Typically presents with acute onset low back pain. Often, but not always, there can be a sciatica, a leg pain component to it. So I really kind of start diving into the detail if they do tell me they have leg pain. And so with this, I'll typically, when I do special exam testing, I'll check for a straight leg raise. If they're telling me they have radiating lower extremity pain, I'll also ask about and check for motor and sensory signs and deficits. So numbness, tingling, focal weakness. So weakness in a certain muscle distribution, difficulty, are they tripping over their foot? Are they having difficulty lifting their foot or their big toe? Things like that. Typically, I'll treat with a period of relative rest, again, not bed rest, similar to the spondylolysis injuries. There will be a period of general rest to allow for some symptoms to calm down and then get them moving pretty quickly. And then, as well, I'll also treat with some as-needed analgesia, followed by physical therapy, really to try and reduce the mechanical stress and tension on the lower spine. It's not to fix the herniated disc. Really, that there's not a good way to fix the herniated disc, and they typically don't completely just resolve on their own. They can improve and get a little bit smaller with time, but that doesn't always happen. The goal is to really try and improve the mechanical forces that are exerted or acting on that joint and that disc, similar to what we would do with any peripheral knee injury. You want to try and even out and reduce those forces that are at play there. So a lot of times I'll specify or emphasize extension-based movements rather than flexion-based movements. Surgery is typically only for significant or progressive neurological deficits or refractory severe pain symptoms. So I'm treating them for 6 weeks, no amount of analgesia, physical therapy, they can't do that, it hurts too bad, it's still really severe. And then further, we may consider doing an epidural steroid injection if there's a strong radicular pain component, so that radiating pain in the leg. But if they're either not up for that or they're in too much pain and it's a significant disc herniation, then I'll have them consult with the surgeon. But otherwise, most of these, you try to really stay with them, and it can take a while. A lot of these can take quite a long time to get better and heal, but you just got to reassure them and counsel them along the way. In particular, since this is a strong sports medicine crowd, high-level athletes may have more incentive to consider surgery sooner, but operative versus non-operative treatment outcomes are generally similar, and I've got a table from a good study representation of that on the next slide. Return to play for these athletes is typically 70 to 80% at an average time ranging from about 4.5 to 6 months. So that's why I say you really got to reassure and counsel these patients, because it doesn't get, usually, not always, but it doesn't usually get better really quick. And so they've got to really I've got to really stay on them about their movement precautions, patience, and really keep them on task with their physical therapy, their home exercise program in particular. But this is largely variable depending on their sport and the demands of their sport that they're trying to go back to. So there's not a whole lot of outcomes by sport in the adolescent population. Those kind of return to sport and long-term those return to sport studies are difficult to find and pretty hard to do. But it's a lot easier to study, come to find out, in the elite athletes, your professionals. So this is just a table to give you an idea what the surgery, the operative and non-operative outcomes are. These were different studies. This was from a review of return to play from outcomes of athletes, professional athletes after operative and non-operative treatment with a lumbar disc herniation. And you can see they're pretty similar, the operative and non-operative return to play rates, both for athletes in the NFL, the NHL, in Major League Baseball, and in the NBA, the top 4 American sports. So there's really not necessarily a move to go to one or the other. And typically in the adolescent or amateur athletes, you're likely going to try and really run out your non-operative course first before you consider surgery. In these higher level athletes, there's often a lot more financial incentive to return as quickly as possible and as soon as possible, both for the athlete and for the club or the organization. So that influences a lot of their decision making. Moving to apophyseal ring fractures, these can sometimes accompany a lumbar disc herniation. You can see there from the picture representation, those are vertebral bodies, and you've got an inferior end plate and a superior end plate with an intervertebral disc in between. And up until about the age of 17, that varies depending on when kids skeletally mature, but up until about that age, those are still apophyseal growth plates. And so they can be more susceptible to injury, like any other apophysis. And separation of this ring apophysis can occur with any lumbar disc herniation. Doesn't necessarily always, but in one study that looked at a review out of Rady Children's, there was about a 28% rate of these apophyseal ring fractures. It's most common at L4-5, and followed next by L5-S1, the L5-S1 level. And it's been suggested that a disc herniation with an associated fracture tends to lead to more severe pain than a simple disc herniation alone. However, that's just a suggestion. There's no clear data to support that, just anecdotally. And large apophyseal fractures tend to have a greater chance of leading to more chronic back pain symptoms, and surgical treatment is more common with this type of an injury than in a simple isolated disc herniation alone. And all it is those Sharpie's fibers that help connect the bone to the disc. Well, when that disc herniates, it pulls that weaker apophysis, and it can pull a fracture of about any size along with it. And so you get a fracture of the bone like any other avulsion fracture. All right, acute compression fractures. This is the most prevalent fracture in the pediatric spine. And what I've got there is, you can see on the left, it's an x-ray. Same patient. On the left is an x-ray. You can see the compressed vertebral heights at least L3, L2, and L1. That superior end plate of those vertebral bodies. Nothing. I promise this worked yesterday, but that's okay. Oh, there it is. Right here, right here, right here. You might say, well, given the right history, if there's a sudden acute pain, there's a sudden injury that makes sense with this, then you can treat that as such. But let's say you don't have that same history, or you just find this incidentally, and you're like, well, is that just more of a developmental variant? And hard to believe, but it's conceivable that could just be, hey, it's just a developmental variant of normal, or maybe they're just not responding to treatment. Well, this MRI, and I actually didn't order this MRI. The patient came with the MRI, but it did show that there was marrow edema associated with those what appeared to be end plate fractures. So at multiple levels, right here, 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 and then actually, even though there's no height loss, there was some marrow edema at L4 as well as L5. So acute compression fractures. Most occur near the thoracolumbar junction, so you can see that it was much more evident the higher you got in that lumbar spine near that thoracolumbar junction. These often heal without surgery, so typically reassurance is a big part of this. Activity modification, got to modify their activities, and often we'll have them get with the orthotist to get a TLSO and use that for 6 to 8 weeks before coming out and getting them moving. A lot of times I will go ahead and, some people don't do this, but I'll go ahead and get them working with physical therapy just to make sure that there's not, especially if they're a more sedentary or low demand kid, just to get them moving, make sure that, because they're probably going to be weak right out of the brace, they may feel a little stiff. I don't want them to have any prolonged symptoms, so I want to get on top of that early. Anterior height restoration of these vertebral bodies typically and commonly occurs, but it can be limited if there's a significant impact on the apophyseal end plate. So it may be something that we follow for a while in some of these kids to see if, just by x-ray, to see if they get height restoration of these vertebral bodies. But you can do that with a simple x-ray. I want to go over a second case. So this is a 17-year-old male athlete with bilateral low back pain for 6 weeks. No history of acute injury. He says his symptoms started after soccer season ended, and he began running longer distances on a regular basis. Symptoms are intermittent and only with prolonged running. His pain is 8 out of 10 on average when present, but he also denies any of those neurological symptoms, no nighttime, no pain that awakens him at night. He plays soccer for his high school team with upcoming plans for a summer soccer league, but he hasn't been playing soccer for a little while since his season ended. He did start weightlifting 3 to 4 days a week about 6 months ago, so he's relatively new to that. No pertinent past medical or family history. On physical exam, he's positively tender over the midline and bilateral spine and lateral spine elements, and his paraspinal is at that level of about L5. Also, the bilateral iliac crest posteriorly. His Stort test is positive on the left. Thomas test is positive bilaterally. That's looking for tight hip flexor muscles or tendons. And then his popliteal angles are about 30 degrees bilaterally. So a little bit similar presentation to the last kid. A little older. He's 17 now. He's not necessarily younger at 14. And like I said, yes, he did. There is a little bit of a change in his training regimen. He began running a little bit longer distance with his off season, but he's no longer. He hadn't been playing soccer for too long, or in a while. X-rays of his lumbar spine were negative. If you're wondering, yes, I did go ahead and get an MRI because of the index of suspicion, although it was a little less in this guy just because of his a little bit older age. It can happen in older athletes, 17 and 18-year-olds, but it becomes much less common. But still was concerned. And other reason being is he was really wanting to play summer soccer, and mom had already signed him up, and that was a big deal to him, so wanted to kind of clear that up for him. So based on that negative MRI, felt it was still okay to go ahead and let him continue to play, but wanted to get him doing some things to work on his core strength, really work on his flexibility. So stressed his home exercise program. I don't recall specifically if I got him set up with physical therapy or not, but in this kid, because that MRI was negative, what I diagnosed him with at that time, at least clinically, was myofascial back pain. And myofascial back pain is, I think, more often responsible, at least in kids, with what a lot of people just term as non-specific low back pain. I just personally, I don't like that term because patients walk away, rightfully so, not really understanding what that is or why they're having their back pain. At least this gives some sort of explanation to it. And what it is a clinical condition described as a combination of sensory, motor, and autonomic signs and symptoms that can be caused by myofascial trigger points. I explain to patients that what I call a trigger point, typically patients call knots in the muscle. They're typically hyperirritable, taut bands of muscle within the muscle belly, and usually you can palpate them. You can kind of rub your thumb over them. They're usually either painful, sometimes, especially more so in the trapezius muscles or the upper back muscles, they may provoke tingling sensations in the hand, numbness sensations in the hand. So it might kind of confuse you and make you think about a cervical radiculopathy, but a lot of times it's more from the just trapezius muscle palpation. That shouldn't cause tingling symptoms with a cervical radic. That's more with neck rotation, neck movement. Just to point out, and I always explain this to patients because they don't realize, I think they think the back muscle is one or two big muscles. There's 28 muscles that attach just to the lumbar spine that run between the pelvis and the lumbar spine, so 14 on each side. There's a large, a very big chance that any one of those muscles can either be strained or develop painful symptoms. Just like you can, I liken this sometimes to patellofemoral pain in the knee, where you don't have any structurally identifiable injury, but a lot of it's believed to be due to quadricep weakness, hamstring tightness. So you start working on those things, and over time, theoretically, the pain should get better. I always try to distinguish between an acute injury, like a strain, versus more chronic pain. Typically, these symptoms are described by patients as dull, tightness, soreness, aching, primarily in the paraspinal muscles or soft tissues, and often without a clear flexion or extension bias. So think a lot of times in kids that have pain with prolonged sitting, prolonged standing, walking a long time, intermittent pain that comes and goes, especially in a kid who's just finished a lot of growth as well. And it often involves that deficit and imbalance in core muscle strength, core muscle endurance, which is distinguished from just pure strength, and in flexibility. So I always check hamstring tightness, hip flexor tightness. I do that by checking for their popliteal angles and Thomas tests, respectively, which I'm not going to go into the details of those tests. They're pretty easily done, and I've covered those in a thoracolumbar exam talk before, but especially these findings in a skeletally growing adolescent. And then with these patients, the focus should really be on improving their back care, so their back wellness. So in particular, again, whether it's with just a home exercise program or possibly adding in the physical therapy component, core strengthening, hamstring and hip flexor flexibility, look at backpack weights, and parents and patients too love to focus on their heavy backpacks. I always point out they should try to keep it less than 10 to 15% of their total body weight, just as a rule of thumb, if they're able to do that or willing to. Nobody really wants to sign up for the rolling backpack at all. And change their posture evenly throughout the day and appropriate techniques for lifting from the floor. I'd say lifting in general, but specifically lifting from the floor so that they're not putting too much stress on their back. So moving on to spine deformity. This comes up a lot. So scoliosis is the first one I'll cover. Most common is adolescent idiopathic scoliosis, followed by the other named causes for scoliosis: congenital, neuromuscular, syndromic, and then there's this much smaller other category. So there have been kind of two big review studies that I'll just present here today to give you an idea of a little bit of the controversial nature of this. In a retrospective study, and this was actually, I believe, a study out of Scottish Rite that looked at 2,400 patients. This was an older study done looking at a population over 10 years from 1980 to 1990. The overall prevalence of back pain in association with presumed idiopathic scoliosis was similar to the prevalence in the general pediatric and adolescent population that was at that time reported by others. However, in a much more recent comprehensive review done just earlier this year, They reported that the reports of back pain in the AIS population is nearly twice as prevalent and often more frequent, severe, and of longer duration than in non-AIS population. Why is that? Frankly, nobody really knows. I'll tell you just as an aside, my personal thought on that is it's more likely, yes, there's this asymmetric spinal deformity, but it's probably also in the context of that myofascial pain that I just talked about before. So you've got a common problem in kids with a complicating issue, like a spine deformity that can contribute to why some kids have pain and others don't. I always tell kids, I don't expect you to have pain because you have scoliosis, but it doesn't surprise me if you have a little bit. However, the causative factors, treatment options remain largely heterogeneous and inconclusive. Important to know that treatment for scoliosis typically long-term does not largely affect the outcome of just general reported back pain symptoms. So whether kids get treated with a brace or not, some may get some improvement in the short term, but at 20 years in those long-term studies that have been done, there's really no difference in the patient-reported outcomes there. With surgery, with more severe scoliosis, there often, again, there is a short-term benefit with pain-reported symptoms. But again, then extrapolating that out 20 years, and some of the international studies that have been done, there's not a large difference in patient-reported outcomes there as far as pain symptoms and back problems. Looking at more of a sagittal deformity, the hyperkyphosis that's typically in the thoracic spine. Kyphosis is normal. Hyperkyphosis is an exaggeration of normal kyphosis in the spine. Much more common type is postural thoracic hyperkyphosis. It is generally poorly predictive of back pain, though, so just because somebody has that exaggerated hyperkyphosis does not necessarily mean that they should or would have back pain symptoms. But parents are often concerned by the appearance of it. Scheuermann's kyphosis is the most common structural cause of hyperkyphosis in adolescents. It involves vertebral bone irregularities at multiple consecutive levels within the thoracic spine. So there's that structural component there. And then although back pain can be associated, the prevalence of associated back pain is unknown. It's not as common nearly as common of a problem as obviously a scoliosis or as postural thoracic kyphosis. And so back pain prevalence numbers aren't really well established, but it can occur. Typically, if it's going to occur, it may occur in the thoracic back area, the upper back, or in the low back due to the compensatory hyperlordosis that often occurs with these patients to keep them balanced. So these are just radiographic representations. There on the right is the Scheuermann's kyphosis. That's typically hyperkyphosis is any curve Cobb angle, which is the way we measure it. Any Cobb angle that's greater than about 45 to 50 degrees. And then the Scheuermann's there, it's a little bit tough to tell because the numbers are there, but that just represents there's anterior wedge deformities of those vertebral bodies that is greater than 5 degrees at multiple consecutive levels. You also can't really see there's some decrease in intervertebral disc height at those levels. All of that kind of contributes to them slowly arching forward. And then there on the left, just representation of moderate right thoracic scoliosis and also a moderate left thoracolumbar scoliosis. So I'm running a little bit short on time, and I want to get to something here at the end. So I'm going to kind of move through some of these last slides here. This is a little bit much less common problem, but I still bring it up for some completeness. This is a pelvic apophyseal avulsion fracture, much more common anteriorly, kind of more associated with the hip. But you can see that there is an attachment on that posterior iliac crest for the TFL and some of the abdominal muscles. So there's potential when patients are reporting back pain to get kind of that far lateral back pain kind of near their posterior iliac crest. Typically, these are due to sudden forceful contractions of the musculotendinous unit, nearly exclusive to adolescents involved in sports, most common with sprinting and kicking, also rotational and twisting sports like golf and swinging a bat. Accurate diagnosis can be made with plain radiographs typically. This was a good retrospective review out of Rady Children's done recently. looking at these type of fractures, and just to demonstrate that point as far as how common they are, only 10% tend to be in the iliac crest, but again, they do occur usually at that TFL insertion. Others there listed on that same line are more anteriorly, except the ischial tuberosity, but that's more kind of near the origin of the hamstring. Excuse me. Initial fracture displacement of greater than 20 millimeters has increased the risk of non-union by 26 times, so a much more serious type of injury, and then 97% of these are typically managed successfully with conservative treatment. Okay, a few other kind of the other causes that we want to evaluate for. So an inflammatory type of back pain, sacroiliitis. It is an inflammation of that SI joint. It's seen in the course of rheumatic and non-rheumatic disorders. Excuse me, all of which I have listed there. Common symptoms include prolonged back pain, insidious onset, symptoms that worsen at night, morning stiffness. Stiffness is a big key for these, especially with rheumatological disorders. Improvements after exercise. So it hurts when they're at rest, but it feels better when they get moving. And then radiation to the buttocks can occur. And that's illustrated by this next, just in just a second, physical exam findings that typically occur along with sacroiliitis, specifically SI joint tenderness, SI joint pain provocation testing on the special testing. I point this out with SI joint pain, but it can occur with any type of back pain, which makes evaluating back and hip sometimes more complex because of the overlap. This was just a good study that specifically looked at SI joint pain and where patients reported their symptoms. So think you have a pain diagram and where they either draw where their pain's coming from or outline the area. And although you might think they're more apt to point right at their SI joint or that area just below the PSIS, they often report symptoms that are in the buttock or even often radiating down the posterior or the posterolateral thigh. So kind of what you might sometimes think of as sciatica symptoms may just be simple SI joint pain. But I don't just point that out because it's SI joint pain. The same is true for discogenic pain, facetogenic pain, hip joint pain. So that further leads to why this is a more complex, or back pain and hip pain can be more complex to evaluate. Causes for increased concern, other than what I just mentioned. So red flags, and this gets into the things that I always want to ask about, and I tell them any patient with back pain, I'm going to ask you these questions or similar questions. Primarily, any history of immune suppression, which I often get from the medical history, or are they on immune suppressing medications? Any nighttime pain specifically, does it wake you up? Not is it difficult to get to sleep, but is it waking you up at night and keeping you awake at night? Peripheral neurological abnormalities, that numbness, that focal weakness, bowel or bladder changes or irregularities, specifically signs of urinary retention and urinary incontinence. These are much more common both in to find or see in both in instances of spine tumors as well as spine infection. Early detection is key. That's why I want to always monitor for red flags. Kind of moving through this. 25 to 30% with a spinal neoplasm. Back pain is the leading complaint, often dependent on the location of the tumor. Neurological deficits and constitutional symptoms are usually, but not always present. Consider in patients with back pain and a history of prior malignancy, immune suppression, or again, that rheumatological disease. And these are best treated by an orthopedic oncologist or spine neurosurgeon. 5-year survival rate of spine neoplasms in kids is about 70 to 80%. It's beyond the scope of this talk, but I just wanted to give some representation. The main thing I'll point out here is that typically with spine tumors, there's extradural tumors, and then there's intradural. And then with intradural, there is intradural extramedullary, intradural intramedullary. Not going to get into the detail there, but 50% are typically extradural. Of these, only about 1% are osseous tumors, so tumors that involve the bone. Intramedullary or spinal cord tumors make up about 40%. They're the most common in pediatrics. This is different than adults. And extramedullary are about 10%. Mets are rare, but the majority, when metastasis is involved, is hematological. And then lastly, pediatric spinal infection. This occurs less commonly than in adults. It's categorized according to location. So spinal cord, nerve roots, and meninges, i.e. think meningitis type infection, and then the vertebra, the discs, and the epidural space. Can involve bacteria, viral, fungal, or parasitic infections. It more commonly affects the anterior vertebral elements, and particularly the end plates and discs, because these are the more vascular areas. So when there's any findings on MRI, we'll often look for that involvement and destruction of those intervertebral discs or the end plates that I was pointing out earlier. Diagnosis is usually made with radiographs, either with or without advanced imaging, but we often get advanced imaging to better characterize and classify these types of problems. Typically, it responds to medical treatment. Surgery is less commonly required, except usually there's medical treatment like antibiotics, antifungals, so forth. And then a higher suspicion in kids with back pain that also have these red flags. So not only the first time I see them, but in follow-up visits, and I tell patients if they start to develop any of these concerning symptoms, please give us a call or come back to see us quickly. And then lastly, often I get the question, similar to what Dr. Ellis asked earlier, when should I order an MRI? I don't necessarily follow this to a T, but I find this is a scoring. They have developed various scoring systems to help when there's kind of you're on the fence or you're borderline. And again, I find these more helpful in cases where I'm on the fence or in guiding folks or providers who don't see back and spine problems as commonly. Really, the goal when you order an MRI should be to keep a balance between taking necessary steps to identify underlying organic pathology and avoidance of an unnecessary and costly workup. Ideally, it should result in a change in clinical management if you're going to order it, or they're not responding to your treatment and you need to roll out other more rare things, zebras. So predictive scoring systems have been developed. The one there on the right is one of the more recent from a good study that was published earlier last year. And this is developed to help determine if obtaining an MRI would actually result in a change in clinical management. And to kind of keep it as simple as possible, those variables there on the left were the variables that they found were most associated or most likely when bundled together to result in an MRI changing your clinical management. They should be used as an adjunct to your clinical judgment rather than a purely predictive tool. So in essence, the more of those variables, the more points, there's points assigned to these variables, the more points that you accrue, it makes it more likely or intermediately likely that that you might find something that would change your clinical management. So it can help in aiding when to go ahead and order that MRI. So I don't know if I doubt we have enough time for this. I'm actually right up against the clock, so if we need to, we can skip, and I can take questions.
I think maybe we'll just transition over to questions right now, if it's okay. But that was a great talk, Dr. Petrasic, and I think we all could learn a little bit more about back pain and how to manage it. Does anyone in the audience have any questions? While they're thinking about it, I've got a couple of questions for you. One of which is, I like the concept of, when to get an MRI and making it more personalized to the type of athlete. And we probably make a lot of decisions based on timing an athlete. I have found in my practice that, if somebody has a condition like back pain and the parents want a solution or they want a very specific diagnosis, and you just want to tell them that maybe just rest is an option. Just give it rest and good movement patterns, physical therapy, home exercise program, but maybe just stop doing what you're doing for 2 months. That sometimes it takes an MRI to convince them that they need to do that, which is not necessarily the right reason to get an MRI. But right now, the parents are so entrusting in just the concept of just give your kid a break from what he's doing. And I think that's obviously what you face probably on a day-to-day basis. When we are evaluating, when you talk about the repetitive nature of these sports and looking at different sports and different movement patterns, do you ever feel as if we should be controlling how much repetitive back extension exercises some of these kids do? For example, pitch counts, right, for shoulder and elbow pain. But for me, I see the most back pain in lacrosse players because they just want to hit against a wall, or the gymnast or the dancer that has repetitive hyperextension. I mean, should we be considering regulating how much time that they're actually doing that?
Loaded question. Yeah, I think it's like anything. You know, I think baseball has been the most successful, specifically in pitchers, because they've been able to establish, at least on some level, pitch counts. But even beyond that, you know, I think it becomes a challenge. I think it would be wise, but, you know, gosh, I would just, it's more difficult than that, though. So I think, just for instance, if you think about dancers and gymnasts, you know, how many back bends, I mean, that's involved in so many of their routines, their skills, their practices. So how do you keep count on how many times they're hyperextending their back when it's such a big part of their performance and a part of their routines? And I think it would be admirable to try, but I just don't know that it's feasible in all sports. But I do think it would be reasonable in certain sports, on a sport by sport basis, to try and establish at least some kind of achievable it's a good question. I know, because I'm trying to think sport by sport, position by position. For instance, offensive linemen, you know, how do you put them on a play count? Do you limit how much time that they spend blocking? I think it just becomes a challenge because our core and our spine is involved in so many movements. I think it would be a challenge to do that.
Yeah, and I think, I mean, you know, it's certainly sports specific, right? And sometimes we just got to tailor that. But I do wonder that sometimes it's so challenging for us because we see such a large range of athletes. How do we limit how much time they do X or Y? Or, you know, it's an interesting concept. But I do think that right now the common thought is more is better, right? I mean, you know, if you practice more, you'll get better at it. And I don't think that's always true, and I think we're kind of abusing the bodies a little bit. Yeah. How do you determine in an adolescent athlete the difference between back pain and secondary gain? I mean, and I use secondary gain loosely, like maybe perhaps the kid who doesn't want to play football, or trying to figure out the difference between, you know, some of that back pain that you just don't have any radiographic evidence of. What are some clinical tricks that you may have to see if the back pain is really truly back pain, or if there's some kind of other secondary gain there, particularly in the, you know, youth sports?
Yeah, you know, a lot of times I feel like I can sense that just in interviewing the patient, getting some of their responses if they're very kind of waffly on answers, because I get in and I ask them very specific questions about their pain, not just where is it. You know, I want them to point it out to me, where, you know, point on your back where it's at, how severe is it, when did it start, how would you describe it, what makes it, you know, exacerbating factors, alleviating factors, everything that we're taught to evaluate pain. But when I'm getting very kind of waffly answers, and you have to be careful with that, because the younger the kid, the harder the more difficulty they have describing, putting their symptoms into words and their problem into words. But still, if I'm getting, you know, very waffly answers, or the patient, when we talk about, because I'll start asking more about their training regimen, and maybe they're insinuating that they practice a lot, but then maybe the parent is coming back, well, no, you spend more time doing it. Well, they kind of seem annoyed by it. That's kind of an indicator already to me, just from the history, that again, there may be some sort of they're kind of tired or frustrated with their sport, and you know, back pain is their way of complaining to their parent or guardian that, you know, I really just don't want to do this. But, there's some physical exam tricks. There's some Waddell signs that can be used on physical exam to try and decipher when and if a patient is really giving full effort on an exam, or if they're kind of maybe subtly trying to sabotage the exam. So, you can combine that kind of gut instinct or intuition from getting that history from the patient and the parent, along with some of those more subtle physical exam signs. It doesn't mean that I necessarily go straight at that and focus on it at first. Likely it's obviously a more benign reason why they're in there. It's not as, I'll explain that I don't think it's a serious spine problem, but that I think, hey, we should try to start treating this and then see how they respond to treatment. If there's a delayed response to treatment, I think a lot of those kids ultimately, with some time, some treatment, at least in my experience with it, time kind of gets them, they finish whatever season they're in. They don't want to do it the next season if they're really not that interested. It gets more challenging the more elite the athlete you get into. So there's special cases there for sure.
Definitely an art.
Yeah.
I think that's the art of what we do.
Yeah.
Last question, and just a quick response, but assuming that most of the back pain that we see, you gave us such a long list of all the potential diagnoses, but the vast majority have got to be, muscular soft tissue or myofascial, type of back pain.
Yeah, I see very few of the other things that were up here. I've seen them, but they occur much less commonly than it may seem by putting them all on a slide deck.
So one of the questions I commonly get, and I would love to know your opinion, are what's your opinion on what I refer to as alternative treatments, such as cupping for the back, dry needling, red laser, all different kinds of lasers, I suppose, I've heard. What are your thoughts on, utilizing that for soft tissue related back pain, or do you believe in that alternative type of treatment?
Yeah, I think there's a little bit of a difference between do I believe in it and is there good evidence to support it, because that gets very tricky. In general, I always ask patients, what treatments have you tried? Have you tried any alternative treatments? Specifically that language, just to kind of encompass, the physical therapy modalities, chiropractic treatment, acupuncture, massage, anything. Because I want to know what did or didn't work. We don't want to, keep beating the same dead horse. But at the same time, I get commonly asked about things when we're talking about these types of treatments. I think the hardest part, to try to keep it succinct, is, for a very difficult question, the hardest part is the cost-benefit analysis. Many patients simply, reasonably can't afford a lot of these treatments that aren't covered by insurance. They're cash-based treatments. But even those that aren't, and maybe they're within the treatment, they don't have a lot of evidence to support them. They may be widely used by a popular elite athlete or in certain sports, but it doesn't mean there's a lot of good evidence to support their use. That being said, more specifically, there is some evidence out there that low-level laser therapy, cold laser, can be helpful for that type of pain. There's some, I think, anecdotal evidence that soft tissue manipulation, I don't know what that was. It's all right. Cupping, those I think really have their place. The dry needling, the cupping right now in more chronic tendinous issues, chronic tendinopathies, and on some level possibly acute tendinitis problems. And I think really the breadth of diagnosis that those are useful and helpful for is still out there. But I think they are all treatments that we have in the bag of in our medical bag. And so if you're trying to pull in things like that, I think you try and maybe use it for a couple weeks, see if it helps, see if it doesn't, if you're able to. But is there a lot of evidence out there to support their use? There's really not at this point, but it's evolving and it's developing. So I think for that really deserves more of a 10-minute answer. That's the best I can do in about 2 minutes.
No, man, that's great. Well, I would say, Dr. Petrasic, we're lucky to have you as a clinician here. You do a great job taking care of a very challenging problem in our patient population. So we are lucky to have you both as a clinician and educator. Appreciate all you've done for us today. We learned a lot, and I would also say that you also alluded to a lot of physical exam findings during a back exam, and I would say that if you guys weren't familiar with all of those terms, he's got a great little 10-minute video on YouTube that you can easily access and learn all about a 10-minute back pain. So if you weren't familiar with those, be sure to look that up, and it's there. So thanks again. I appreciate it.
Yeah, thank you all very much.